Good morning, students. Today's class we'll see about the immunology in pregnancy. Pregnancy is a unique event in which a genetically and immunologically foreign fetus is usually survived to full-term infant without apparent rejection by the mother's immune system. Over the past decade, more information has been gathered to provide insight into the complex immunological mechanism that allow the fetus to grow and survive in most cases. Whereas maternal fetal interference was once felt to be an immunologically privileged site with complete separations between fetus and the mother, it is now known that recognition of foreign fetus does occur. However, despite this immunological recognition, several mechanisms have been discovered which may explain why the mother do not reject the foreign fetus. Pregnancy is an immunological balancing act in which the mother's immune system has to remain tolerant to the paternal major histocompatibility antigens and yet maintain a normal immune competence for the defense against microorganisms. The maternal immune system during pregnancy is altered to actively tolerate the semi-allogenic fetus. These alterations include change in the local immune response, that is, in uterine mucosa, and changes in peripheral immune responses, both in shallow and over invasion, will lead to problematic pregnancies. Heightened state of immune system lasts for 12 weeks of pregnancy to allow the fetus to fully establish. Over the following 15 weeks, the mother's immune system is repressed to allow for the fetal cells to grow and develop. Many obstetric problems are now explained with the complexity of immunology. The basic immunology of pregnancy include one tissue that is repeatedly grafted and repeatedly tolerated is the fetus. The mysterious mechanism of immune system that prevent rejection of fetus remain unknown to the immunologist. Why fetal allograft receive half of its histocompatibility antigens from the father is not rejected. Successful pregnancy itself is a immunological paradox. Some complications in pregnancy are associated with underlying immunological etiology. For better understanding, some areas of basic immunology are discussed first. The immune system generally divides into innate and adaptive. The innate immunity system is the first line of host defense against infection. It works fast once it recognizes the pathogens. It cannot identify the self versus non-self. It involves complement system. The immune cells involved are phagocytic cells, natural killer cells, eosinophils, and basophils. The immune responses are by release of cytokines and chemokines. The phagocytic cells ingest and digest microorganisms with lysosomal enzyme. The NK cells are recognized. NK cells means natural killer cells. Can recognize the distinguish between normal cells and cells infected with the virus tumor through the expression of MHC. MHC is the major the class 1 antigens, and the NK cells destroy cells. NK cells destroy cells that are deficient in HLA class 1 molecules. Major histocompatibility complex, or MHC, is the most complex genes with multiple loci. It is located on the chromosome 6. MHC encodes two types of membrane proteins. Those are known as human leukocyte antigens class 1 and class 2. The process of graft rejection generally involves in the recognition of foreign MHC. MHC is major histocompatibility complex molecules by host T1 lymphocyte. Second is adaptive immune system. It works on second line defense against infection. It has the delayed response. It can discriminate self from non-self. It prevents reinfection through the immunological memory. It contributes mainly by two types of, that is, lymphocytes and antigen presenting cells. The T lymphocytes are classified into T helper, T cytocytic. The TH means the T helper cell have two subtype TH, the T helper 1 and T helper 2. The T helper 1 cells activate macrophages and involved in cell mediated immunity. The T helper 2 cells activate B differentiation and involved in humoral immunity. Immunology of pregnancy. Pregnancy is an immune deficient state. The women are able to respond both humoral and cell mediated immunity against paternal antigen. Specific type of NK cells are present in decidua, mainly at the site of implantation. These cells are differentiated from the blood NK cells. These UNK cells, uterine natural killer cells, control the trophoblastic proliferation inversions when they interact with HLA class 1 molecule. UNK cells depend on the progesterone for survival. NK cells share many antigenic functional similarities to T cells. There is a high proportion of NK cells in fetal circulation up to 13 weeks. Due to their high number, early presence and ability to kill cells is likely that these NK cells are very important in fetal innate immunity system. Uterine macrophages are major source of nitric oxide and prostaglandins. The trophoblast cells are derived from fetal tissue and invade decidua. These trophoblast cells form the interface between the fetus and the mother. Thus, the placenta forms an efficient barrier against the transmission of immunocompetent cells between fetus and mother. Trophoblast covering chorionic villi comes in contact with maternal blood with intravillous space. Trophoblast is in contact with decidua, express HLA class I molecules but not HLA class II molecules. Placenta presents to immunocompetent cells due to lack of HLA antigen. During pregnancy, maternal immune response is shifted to immune from T1 to T2. T2 type response beneficial due to production of anti-inflammatory cytokines. During pregnancy, there is a production of antibodies to paternal antigens. These anti-HLA antibodies and antibodies against sensitized T cells. Immunological mechanism involved in pregnancy are not the same that of organ transplantation. Immunological tolerance through the complement that cytokines regulation is protective for the pregnancy. The relationship between HLA matching between partners and fetal loss is not based on any evidence. Other postulations are maternal fetal cell trafficking and microchemism. The maternal tolerance of fetus is due to bidirectional level of trafficking between the mother and the fetus. Cell-free fetal DNA and also infant fetal cells are detected in maternal circulation during pregnancy. Immunosuppressive factors that operate in pregnancy are estradiol, progesterone, HCG, and prolactin. Fetal tolerance is probably due to the presence of alpha-fetoprotein. A number of pregnancy-associated glycoproteins, example alpha-2 microglobulin and plasma interferon, have immunosuppressive properties. Immune tolerance. Immune tolerance of normal pregnancy at maternal fetal interference maintained by the interaction of HLA-G with uterine natural killer cells. The effect is predominant in normal pregnancy. Second is ABO hemolytic disease of the newborn. Jaundice in newborn infants within 24 hours of birth due to ABO-ISOIMMUNIZATION of the mother. The incidence is higher in group O mothers carrying a group A1 fetus. Except for the fact that A1 antigen is strong, it has not been clearly known that why A1 fetus mostly taken out to the brood. Third is Rh-ISOIMMUNIZATION. Though entry of fetal blood in the maternal circulation can take place at any time during pregnancy, fetomaternal bleed is not common in the third trimester, but particularly during the separation of placenta. 0.1 ml of Rh-positive fetal blood is sufficient to bring about immunization in Rh-negative mother. Immunization against anti-D and Rh-D antigen is most frequent as D is more potentially antigenic than other Rh-negative antigens like C and D. Under these circumstances, the mother will form that anti-Rh-D agglutinin which passes again and through the placental barrier into the fetus, giving rise to agglutination for hemolysis of the fetal erythrocytes, which ultimately may lead to dangerous situations like herpes fetalis, icterus gravis neonatum, or kernicterus. Preeclampsia. In eclampsia, the abnormal immunological response develops in two stages: abnormal placentation and spiral artery remodeling. It is due to decreased placental HLA-G expression. HLA-G is a major role in placentation and blood flow development as observed in normal pregnancy. This means there is a failure of extravillous trophoblast and invasion of spiral artery remodeling. This is due to a failure of interaction of extravillous and trophoblast with uterine natural killer cells and HLA-C receptors. Preeclampsia associated with widespread systemic inflammations and endothelial dysfunction. The immune dysfunction of preeclampsia follows. There are decrease in regulatory T cells both in number and function. There is a higher level of cytokine abnormalities. In eclampsia, there is an abnormal maternal fetal immune interactions. Sporadic and recurrent miscarriage. There are some observations suggesting an immunological interaction in case of sporadic and recurrent miscarriages. Cytokines are immune molecules. In normal pregnancy, there is a shift of T1's response to T2 response. The progesterone has immunomodulatory role to induce pregnancy, protective shift from T1 cytokine response to more favorable T2 cytokine response. Women with recurrent miscarriage produce low levels of T2 cytokine. Women with recurrent miscarriage have decreased population of natural killer cells within the decidua. However, evidence to support the following are the incompatibility of HLA antigens between the couples, absence of leukocytokines antibodies in the mother, absence of blocking antibodies in the mother, testing for peripheral blood natural killer cells. Antiphospholipid syndrome. Innocently, and the antiphospholipid antibodies like lupus, anticoagulant, and anticardiolipin are important. These antibodies act by dysregulation of the coagulation pathways. This causes thrombosis of uteroplacental vessels and poor placental perfusion. Obstetric complications are due to this pathology. Maternal autoimmune disease and fetus. Incidence of fetal thyrotoxicosis is higher in babies born of thyrotoxic mother. A baby born to a mother with ITP will all probably suffer from the same disease through the transplacental transfer of antiplatelet antibodies. Myasthenia gravis also have some such relationship due to transplacental transfer of the acetylcholine blocking factor. Babies born to a mother suffering from systemic lupus erythematosus often develop congenital heart block due to transplacental transmission of anti-RO and anti-LA. SLE patients have very often exacerbation of disease activity during pregnancy or in the early postpartum phase. All these diseases listed in this group manifest anxiety in the newborn. Immunological control of fertility. Placental hormones like HCG that cross-react the luteinizing hormone, thyroid-stimulating hormone, and follicle-stimulating hormone has beta subunit. This is not immunological so as to couple with the happen antibody production. Of many anti-HCG vaccine, most effective being one that directed against C-terminal peptide and beta subunit of HCG. The antibody does not cross and react with LH and throughout effective up to 12 months. Human sperm antigen. Of the numerous sperm antigens, antibody against LDHX is being currently evaluated, and there is a significant reduction of viable sperm as well as improper implantation of the ovum experimental in animals where anti-LDHX antibodies injected to them. Suna pellucida is most extensively studied potentially oocyte target antigen. Anti-sperm antibodies are present either in the serum in the productive the antibodies present in the female reproductive tract that binds the sperm surface antigen affect the motility and sperm and may cause infertility. Maternal immune system during pregnancy is altered to actively tolerate the semi-allogenic fetus. These alterations include changes in the local immune response, that is in uterine mucosa, the changes in the peripheral immune response. During pregnancy, the cell-mediated immune response of the maternal specific immune system is relatively suppressed, and that this suppression seems to be compensated for by activation of innate immune response. Thank you.